I think that the state of AI is such that a human in the loop is a must, right? So if you have got a trained radiologist who is using AI as an assistive tool just to cross check whether she has missed something, an expert user, I think that she'll be able to control and use it well.
Hi, I'm Jhalak,
Hi, I'm Fawaz.
and welcome to the CCG Tech Podcast.
Right. Thank you so much, Professor Subhashis, for joining us. And before we begin, for our listeners, could you just introduce yourself and outline some of the work that you've been doing?
Hi, thanks for inviting me to the session. So my name is Subhashis Banerjee. I'm a professor of computer science at Ashoka University. So I'm a pretty conventional computer scientist, but also do machine learning and AI. I head the Center for Digitalization, AI, and Society out here, and also part run a center on digital health. So I have been thinking about some of these topics of safe use of AI in healthcare. Happy to resume, have a conversation.
Thanks for joining us, Professor Subhashish. I think in the Indian context, there's been a lot of focus on using AI for social good. And one of the key sectors that we've seen a lot of government focus has been around the healthcare sector. Could you tell us a little bit about the kind of AI applications we are seeing emerge in the healthcare space? Ranging from say diagnostics to radiology to pathology, and how do these systems generally function?
So I think in India, AI in healthcare is just beginning to happen. They are not very common except in research centers to use them for diagnostic purposes directly. But almost any equipment that you buy these days, be it an ultrasound machine or a breast mammogram scanning machine or MRI machine, they all come with a machine learning tool. So by default, and most hospitals in India have not yet started using them, except in an experimental basis. But I think that the bigger centers have started playing around with them. They're sort of testing waters. There are research systems that are installed at several hospitals. So, for example, we developed some from IIT Delhi that are installed at AIIMS, and they're in experimental use. But I think that the way the machines are having AI systems integrated, it's only a matter of time that we see a large scale use of this system. So apart from diagnostics, the other kind of AI systems that are being talked about are models, are computational models for biological phenomenon, or for example, like COVID, the epidemiological model of disease spread. Lots of people tried that all over the world, and some with disastrous results. And there were several such models also from India, including an official from Department of Science and Technology. They inform policy to the extent to which I don't know, but they were certainly put out there in public space to inform policy. So apart from epidemiology and things like diagnostics, there are also these studies like study of antimicrobial resistance. AMR, there's a big problem in India, so AMR is a nightmare. And exactly how to tackle AMR, the extent of which from sample data, there are lots of groups that are trying this to understand this using AI in the research domain. So they are not in the public space as yet, but there are a variety of research groups that are trying out various methods to study these kinds of problems.
So if we take an example of a diagnostic system, you mentioned that increasingly a lot of the new MRI machines, ultrasound machines that are being installed in large hospitals have a machine learning sort of capability. So could you break down for our listeners on what role this machine learning capability could play and how hospitals could leverage this and what the benefits could be?
For example, take a system like breast cancer, right? Now, that's a big killer in India, and most varieties are believed to be curable if detected early enough. So there is a definite public health need of screening people early. And in India, for a variety of reasons, unknown reasons, I mean, the onset of breast cancer is at least a decade earlier than in the West, right? And women as young as 35, 40, they're getting it. And this is a disaster, it ruins families. And so there's a lot of merit in trying to detect them early. And but unlike in the West, the screening is not very common. And the reason the screening is not very common are the facilities are not very common. There are not that many radiologists, there are not that many screening equipment. And screening only happens in the big centers like Max, AIMS, and stuff like that. So, screening at the primary healthcare centers, or putting up screening equipment and doing it at a community level, this is not done. And the reason, so the mammogram equipment and the training may be given to people how to operate that equipment fairly easily. But we are woefully short of radiologists, trained radiologists who can look at that and take an informed decision. I mean, I think that we are ridiculously short of radiologists, and I don't remember the numbers, but they're mind-boggling. So there's a lot of merit in trying to do a initial screening with AI, right? And also not with a mammogram device, perhaps, but with an ultrasound device whose penetration is more in India. So they're used for gynecological purposes, much more common, and it's a slightly unusual medium for breast cancer detection, but because of the penetration, there's some merit in trying that as well. So there's a lot of merit in doing so, but doing it correctly is a different question altogether.
Yeah, I think doing it correctly is where we want to take this discussion, because you're outlining specific use cases, and healthcare, if we look at the recent history, last 100 years or so, healthcare is a space with a lot of rapid technological adoption, and where technological adoption has very concrete, measurable results, which is also why we have very established standards and procedures for how it should happen. My question to you is, when it comes to AI, do you think that these established standards and procedures are good enough to do it correctly, as you said, or is something radically different about AI that we should have a completely different approach?
So I would think that AI is a different beast. So typically, when you talk about a medical intervention, like for example, a drug, right? A drug would have a molecular theory, a biochemical theory, a immunological theory. So a drug would come for testing provided it has passed all these kind of theories, right? So depending on which space the drug is, if it's an antibiotic, it'll have a theory of what kind of antibiotic response it has. So it's not a purely data-driven approach, right? And finally, when you have evaluated its efficacy and safety from standard biological theories or biochemical theories, you would put up a drug for a randomized controlled trial in some location, right? And a randomized controlled trial will separate people out into a treatment group and a control group, trying to keep everything else the same. And then you would go through 3 phases of randomized controlled trial. That's an established protocol in drug design, and things would come up. Now, the randomized controlled trial protocol is well known that has very poor external validation, which means that you've done it at one place, on one population. Now, whether the sample that you have collected represents the entire population is unclear, right? So, for example, you did a randomized controlled trial at AIMS Delhi. Whether there is a demographic difference if you try to deploy in South India or in Africa is largely unknown. So that would be an external validation problem. So you would not know that how the effect of the study will carry over to other situation, other distribution, other demographics. But you still do it because you're only doing a cross validation. You have other theories that support it, right? But in case of AI, it's purely data driven theory. So there's no biology there, there's no physiology there, there's no biochemistry there. You've just taken data, you've trained the system for its predictive power or its generative power, and that has by itself very poor external validation, right? The reason that it is poor external validation is that typically you'll collect a data set, large data set, and use that data set to train a machine learning system, right? So, for example, take breast cancer. How would you do it? You'll typically take General Electrics. They are the biggest manufacturer of mammography equipment. So they'll collect a population of people. They'll try to make it as representative as possible. And they'll have a large data set, which is annotated data set, which means that a radiologist has marked this as tumor, as benign, as cancer, as stage 2, stage 4, calcification, right? So typically you will give a BIRAD rating. BIRAD 0 is clean. BIRAD 1 or 2 means problematic zone. Above that, you're uncertain. So you'll take this label data and you'll train a machine learning system, right? Now that machine learning system has got fixed in most cases. So just learned and got fixed. And now you have no idea where the data came from. Probably it's Caucasian data or North American data. And now that system has been bought in, say, Max Saket, where the demographics are completely different, the fat content is completely different, the muscle content is completely different. So a cancer in a different physiology may present in a different way. So you don't know the efficacy of the system that was trained and evaluated in a certain situation. How will it work in South Delhi, right? No, ideally, so that's the reason that machine learning systems have very poor external validation. So ideally, what you have done is that you have built a local data set and test on it. But most places don't have the resources to do this, or the wherewithal to do this. Even if they have the resources, they don't have the know-how to how to do a statistical testing of a machine learning system. Very few centers. AIMS will be able to do it, but they're so pressurized with. Yeah.
Sorry to interrupt, but I could just ask. For our no more non-technical audience, if you could just say what do you mean when you say a local data set that most places?
Local data set is some data set that you collect from a population that visits your hospital. Yeah.
Got it.
So you have to collect a large number of women who have got screening done at AIMS or Max and so on and so forth. And that data set will have to be statistically large enough. And now you have to test that system against your data set. And now if you see a performance drop, you will say that the machine learning system requires retraining or retuning and so on and so forth. Now, the trouble is that most hospitals are so busy that even if they have the ability to do so, they will rarely do so. Right? It requires a lot of expertise to do a statistical testing of a machine learning system. So that's why it doesn't have an external validity. Now, if you test it using RCT, which also doesn't have an external validity, there's a bit of a logical problem out there. So I think that's the problem that machine learning is facing right now. That how do you generate trust on the reliability of a machine learning output?
You talked about how the lack of theory, and in your public commentary, you've also talked about how if there is going to be a theory of AI, it's probably not going to come from computer science. It's probably going to require other disciplinary approaches. How do you see that sort of having an impact on these kind of on healthcare applications, for instance?
I think that the modern machine learning has come from computer science, right? And I disagree. I think that if you ever understand it, the theory will come from computer science. But we are very far from it. The reason that you build this machine learning system is because there are encodings that you cannot describe verbally, right? So if we could say that this is the breast cancer because you see the tumor here and right, so you cannot verbalize it. If you could, then you would write a non-machine learning program for it. So you are using machine learning because you cannot describe how to solve the problem, and you're expecting the machine learning system to figure out uh, correlations and encodings from the data itself, right? So these systems will never be explainable. In fact, explainability is a bit of an oxymoron. You're using machine learning because you can't explain it, right? So even if you have a theory, so the theory that you're looking for is not an explainable theory, but a theory of putting some kind of a performance bound on the results. See, AI is probably the only engineering system that we use which doesn't have a specification in terms of performance. When you build a bridge, you say that this will withstand this kind of a load, this is the chances of failure, it will fail under these kinds of considerations. With AI, you can't say when it will fail. It may detect, as we have seen, really complex breast cancer cases where trained radiologists have missed it. But then it has failed to call out to breast cancer when even I could see the breast cancer, clearly, and a completely untrained person. So its failure points don't coincide with human failure points, and that's a big problem because if you miss an obvious breast cancer in screening, you're actually giving a death sentence because 1 year later it'll become completely untreatable. So the evangelists will argue that look, right now you're not even screening. So even if you do a little bit of screening, it is all right. So those are actually big ethical questions, and it cannot be answered from technology. I think that policy makers and lawyers will have to come into it and be debated in the society. Yeah.
So, Bishish, very nicely over the last few minutes, you've sort of charted out some of the challenges that we face, with the way AI-based diagnostic tools currently are. Whether it's, how do you test against localized data sets to see how successful these models will be, in the Indian context. Questions of whether the decision making is explainable or not. What are some of the other challenges you see? For instance, you spoke at a CCG workshop on fairness in AI, and you talked about various questions of discrimination, bias, fairness. The questions of human in the loop on AI. What are the feedback loops also in the medical space, where if AI is getting something wrong, like what is the kind of feedback loop? What is the kind of human oversight required over decision making? So, can you talk us through some of the other challenges you're seeing in the AI diagnostic space?
Yeah. So we have sort of covered reliability. The biggest unfairness is an unreliable system, and
Yeah.
unleashing an unreliable system on the population. But even if the system is doing what it is doing, there is always the risk that it will not do so equally for all groups. And, for example, machine learning systems for breast cancer, if I stick to that example, will do better for Caucasian people. There's no question about it. And the reason is that there have been years of data collection on Caucasian people, right? I mean, on North American people. The centers that have started this research years back, Stanford Medical School and Johns Hopkins, and they're all North American colleges. So you can see that there is no way a data-driven technology can start with equal representation of all kinds of people, right? So I have no idea now if I deploy a system at AIMS, whether there are, how will it work on a tribal from Jharkhand? Because there's no data. So there's no way to say that there's no difference. Somebody may say that, look, breast cancer is a breast cancer, there's no difference. But that cannot be said for sure, because the factors that obscure a cancer is different. So So there is inherent unfairness because of an unfairness in the society that not every section of the society is equally represented in the data set. And that is going to create some bias. So I will almost surely have different accuracy rates for different sections of people, even without being discriminatory in the design, right? I mean, and this is more true for language-based models. So when you talk about language-based models, they have been largely been trained in English. The corpus is English language because look, Bengali just doesn't have so much of PDF, right, or content to train a language. So your sensibilities are English sensibilities. Your grammar is your language constructs are English driven. So now, if you are trying to build a large language model-based system to advise pregnant women in rural Jharkhand, how will it play out is anybody's guess. So there are lots and lots of attempts of using large language models so that people where primary healthcare centers don't work that well can talk to a chatbot and get advice about pregnant and lactating women. They can get advice about immunization, hygiene, health, medicines, so on and so forth. I think I know at least 20 groups that are trying to build those systems. The trouble is that when you try to build a system, your data set will obviously be collected from a narrower region, and you'll try to deploy elsewhere. And there is no principled way of how to test it in a deployment situation, right? It is sort of on a best effort basis, and such a system will obviously not perform equally from all sections of the society. Right? The more privileged one will have better representation, so it will likely to work better for them. And there's no way to avoid that problem. In fact, we have got a theorem in computer science says that fairness is impossible unless the data is very, very well behaved. But if the social society has biases, those biases will creep in.
Human in the loop is very often talked about as one of the ways to, in any AI system, we constantly talk about human in the loop. But when it comes to healthcare, how far does that go? How far does that take us in ensuring safety or
Right now, I mean, this is my personal view. I don't think there will be agreement among computer scientists or even people who want to deploy it and policymakers. I think that the state of AI is such that a human in the loop is a must. Right? So if you have got a trained radiologist who is using AI as an assistive tool, right, just to cross-check whether she has missed something, an expert user, I think that she'll be able to control and use it well. Right? As many of my AIMS colleagues are using it for those kinds of purposes. But the human in the loop is not always possible. And the evangelists of AI, they say that the real advantage of AI comes without the human in the loop. I mean, look, healthcare is the biggest challenge in India. We can't man our primary healthcare centers, right? So even if there's a human in the loop, that human will be an ASHA worker in a primary healthcare center, right? And now from a AIMS radiologist to an ASHA worker, there's a skill difference that is also decision-making ability difference that is enormous, right? And now I cannot say how will it play out, So it will be probably different in different situations. So if you make the argument that, look, right now, an ASHA worker working in a village, rural Haryana, she's not even scanning for breast cancer. Because nobody is getting screened, right? So people are just, you get a breast cancer, you die. So even a faulty screening is better than no screening. That can be one line of argument that can be put out. At least few people will be saved. But the counter argument can be that if you tell a rural woman that you have cancer when she has none, apart from all the mental trauma, she'll lose 1 lakh rupees straight away. The kind of test that will start this, that, travel to a big center, a disruption in the family. So the cost of a false positive is very high. And the cost of a false negative is probably death. So this is an ethical question. I mean, this is a question that no technologist can answer. I think the society will have to understand the issue, debate it, and figure out whether to use such a system without a competent man in the loop or not use it at all. I think it's not an easy question to answer. Same with this. If you ask me that should you advise pregnant and lactating women using large language models, my computer science training would tell me no. Right? I mean, that thing can hallucinate, say all kinds of wrong things. Right? Now, if you put me the argument that she's not getting good advice anyway, right? She's getting rubbish advice, and at least this thing will give her right advice at most times. I don't know how to respond to that, frankly. That's a tough one.
So Bashish, one of the things we're seeing arise globally
Mm,
is sort of pre-deployment, a sort of a risk assessment, and then
mm.
post-deployment at a certain
Measurement.
frequency, some kind of auditing. How do you, and many of the things you've talked about in the context of diagnostics and healthcare seems to point to that perhaps that risk assessment is not really possible, because unless you have those localized data sets against which these AI healthcare diagnostic tools can be tested against. Say something is, as you were saying, developed in Sloan Kettering in the US and then is being deployed in whether South Delhi or rural
Mm,
Jharkhand.
mm, mm.
Unless you have those localized data sets, how do you do that initial risk assessment?
Yeah, even if you can do it in South Delhi,
Sorry.
whether even if you can do it in South Delhi because you have Ames and Max, whether you can do it in South Jharkhand is, yeah, that's a very difficult question. So yeah, I think that theoretically a pre-deployment risk assessment is a absolutely mandatory step, right, for any AI deployment. But I don't see that happening very easily in India. It's not an easy thing to do. And you require real high quality trained manpower, trained in biostatistics and stuff to be able to do that. And those kinds of skill sets are available with very specialized centers only. And not every center is able to do that. Most small centers will buy and expect it to work, right? I mean, and and in that case, as you correctly said, that we require post-deployment measurements, very strong measurements out there. That also is not easy. Measurement can only happen with respect to a ground truth. So, so you require a ground truth from somewhere to come up. How will you generate ground truth in rural India? Because you don't have ground truth because there are no trained radiologists out there, right? So how will you even measure the false positive and the false negative rates? The positive predictive value, or whatever you're measuring. So I see that as a big challenge. That not because of a technical issue. Of course, a competent team could do it. But how will you put together such a team in various deployment scenarios is sort of an open question to me.
So, for our audience, Subhashish, if we had to take these two scenarios that we've been talking about, right, the South Delhi scenario and then the rural Jharkhand scenario, and if, say, we were to talk about a 5-year timeline, right, what sort of infrastructure, technical capacity, skilling, individuals, regulators, organizations, institutions do we need to now be investing in today to be in 5 years perhaps able to bridge some of these gaps for broader deployment and better utilization and harnessing of the potential of AI?
I think that while AI can help, this is my personal belief, it cannot be a substitute for the fundamentals, right? I mean, you have to invest in the doctors, the manpower, the pay the ASHA workers, right? I mean, those fundamentals will have to be done right because even if you can set up a system that can do a risk assessment and post deployment measurements, that will have to be a skilled manpower. So skilling is important. And if the skilling is done properly, then maybe some of this AI use can be minimized. For example, certainly the pregnant and lactating mother and the immunization advice, you don't need AI. I think that if you have skilled manpower, then the skilled manpower can do that job very easily. For the very high-end cases, like breast cancer, like an MRI, like an ultrasound-based screening, for example, operating a mammogram, most ASHA workers will not know how to do it. They'll require tremendous scaling. Or, for example, if you are doing an ultrasound-based intervention, and ultrasound, so mammogram is a static thing, but ultrasound, you have to move it. That requires further training because you move the probe uh, actively, right? To be able to, you can provide aids to the person who is conducting the ultrasound that you've not covered the entire region. Go a bit to that region, but ultimately it will require a lot of skill from that person. So I don't see that how AI can avoid the skilling exercise, right? The skilling will anyway have to be done. So your shortage of medical medically trained manpower, that problem is going to bug you, now or forever. And I think that it'll sort of naive to expect AI to solve that problem. That's that's my view, but I have to add the caveat that there are many who don't think like this. So
So besides the skilling piece, Subhashish, over the next 5 years, what kind of capacities, infrastructures, systems do we need?
first is also lots of AI trained manpower who really understand it, who can tell snake oil from the real thing, and there's a lot of AI snake oil going on. So now with this kind of everybody and their aunts are doing AI. If you look at students, their ability to tell snake oil from rigor is sort of zero. They try all kinds of things. People are saying that sentiment analysis for job interviews using AI. Come on, that's snake oil. You can't do that. That's so image is self-contained, right? And at least take a breast cancer image that is self-contained. All the information is there. When you're interviewing somebody, there are more omitted variables than real variables that you have measured, right? How can you even do sentiment analysis? So I think that even the training in AI has to be rigorous. Lot more people need to understand the technology better and not go by faith-based soothsayer kind of methods, belief system in AI. So I think that in both fronts, in medical training, in AI training, we have to cross quite a bit of barrier before we can start using them effectively straight away. But if you are saying that it is for screening only, not for intervention, as lots of my colleagues at Ashoka are saying that we should immediately start using it for screening. Lots of my medical colleagues at AIMS also think that way because they think there's absolutely zero screening that is happening in India. Also for lifestyle diseases like diabetes and hypertension. Apparently, every adult is either diabetic or hypertensive, and an early intervention, early warning in the 30s can go a long way. So there are a lot of people who are saying deploy the systems, at least for screening level. You don't do a direct intervention, but so that they get a warning to go report to a health center or somewhere to get them some check. What is the cost of a wrong signal to a while you're doing screening? Right? Those are tough questions. I think that people who have practiced medicine on the ground will be the best to answer that. Which of the two risks is lesser?
If I can ask a tangential question, because you've been
Sure,
talking
please.
about, you mentioned snake oil, and we see it in every space where there is a problem because of a resource crunch. You have somebody plugging in AI solutions, and as you said, op- some you can characterize as optimistic, but there are quite a few which are just snake oil. Being in this space, like having a view of different stakeholders, even though we know you're not a policy person, but still, what is your view of how policymakers or other government stakeholders are looking at AI in health right now? And I'm not talking about, I'm not asking you to pin down people or who said what, but yeah, a general sense of what is the view, what is the approach that you are encountering.
So, I have not talked to many government officials in the Ministry of Health on this, but I have seen people in ICMR, scientists mostly, because the push comes from them. The more policy making types from the scientist community, and there is certainly a big push for AI. There's a big push from WHO in AI. There's a big push from I think that most people think that AI is inevitable, and in the long run, a good thing, right? I mean, if you use it correctly. Um, they talk about responsible AI, right? Everybody is clear that you have to do responsible AI, but the responsibility is easier said than done. That's what bothers me a little bit. So I think that a lot of talks about AI that goes on, and what is scary is it is misinformed. The real risk, the real capabilities are not quite understood, right? And even when students are trained, they're trained to build it for results, but not evaluate them with full rigor, right? So what does it mean to do a risk assessment, full statistical testing of fairness? I don't think that even students are trained, even at IIT, with many of these things. So some of these concerns are a little underplayed, right? And in the haste to show that, look, here is my AI system, which works with 90% accuracy. Now, 90% accuracy is on a small data set, but if you expand it out, how will it play out? That requires a rigorous evaluation. That understanding is a little bit missing. And I would think in AI, that is the understanding that is required the most immediately.
I think that's very helpful. And again, like slightly related, a lot of the times when when you encounter the critique that the data we don't have sufficient data, or the data is very poor to for AI systems to function properly, to be trained properly, things that you've also been saying. The response from evangelists or proponents of AI adoption is that this is the problem. We are too restrictive about protecting data. We need to make more and more data available. We need to make sure that everything is digitized. Do you feel that the problem really is that there is a lack of data, and the solution is that we loosen up maybe data protection restrictions to make sure more data becomes available? Do you think that will, regardless of privacy concerns, would that lead to an improvement or a solution of any kind?
Data protection, no. I think that um, the Data Protection Act is not implemented in the hospitals. I know, right? So I think that's not the reason for lack of data. Look, AIMS is chaotic. They have no system for, except in smaller groups, they have no real system of cataloging data but and to be fair to them, they're busy. They're just incredibly busy. Most of the research, I don't know how they do research after 10 hours of clinical work. So, to pay attention to the safekeep of data and proper cataloging of the data, it's a tough ask, so they need separate data teams to do that. So I think that most big Indian hospitals are poorly organized. Max is the best that I've seen. So we use some of their data. Yeah, they are the only ones that have got a data lake, probably because they can afford it. And, Ames being government is completely chaotic. So I think that in India, we have poor data standards and data policy. That needs to be addressed. Now, if you have the data, suppose you can gather the data and put it together in a usable manner, then the question of privacy will come up, right? And I think that then you require laws, whether the Data Protection Act that we have passed gives adequate protection, and I have my doubts, right? Or ABDM looks too simplistic to me from that angle. And whether it even addresses the concerns that have been raised in India adequately are unknown. And also, the Data Protection Act or the Disha Act or the ABDM, I don't think that they adequately even address AI. I mean, they don't. The DPDP Act is silent about it, right? I mean, more or less. So AI, the data end of it, the input is one concern, but the output is also a concern. Because you are doing inference from the data, so you have no idea of what kind of correlations or privacy violations you will find at the output, right? And there are no standards out. Yes, data is an issue. We need to collect data, but if we collect data, then how to use the data, that also requires more effective standards than the AVDM currently specifies. I think that the problem has not been conceptualized adequately.
Many of the global standard setting bodies such as ISO or BIS in India have been attempting to frame standards around AI in different
Hmm.
domains of AI. What do you think? You've been referring to the need for say standards in the context of healthcare data, right? So, what are the kind of standards we need? If you could maybe talk specifically about, okay, in the healthcare data space, what are the kind of standards when you talk about standards we're referring to? And more broadly in the AI healthcare space, besides data, what are the other kinds of standards we need to be thinking about?
I think that if you're taking AI data set in a context like in India, the first thing that you have to say that when you're training a system, what is the representativeness of the data? How do you evaluate that the data is representative? Is representative of what demographics, right? Um, is it adequately balanced towards various things? Even if it is not, it's important to articulate that. So you know that, look, this is confined to this group and that group is missing. So when you extrapolate, be careful. So the provenance of the data is most important, right? And how the data was collected, where has it come from? The second is that, what are the kind of inference engines you have used? What kind of machine learning model you have tried, right? Is it a foundational model that is you've downloaded from Stanford and fine-tuned it on Indian data? Or is it an ab initio training? What are the consequences of that? So, so those are one set of rules that tell you about the reliability and the fairness angle of the systems that will be able to come out of the data. The second set of rules are about data protection itself. That how will you share the data? What kind of de-anonymization attack I can orchestrate on it? Because once you have medical data, there will be foul play. There is no question. There is never in the history. So it's commercially too important for people not try to grab it. So what are the data protection standards? And what are the fair use policy? What are the competition laws around it? Uh, am I as a researcher likely to get access to the data? Or I'll be told that you stay out, right? So, you know, what kind of researchers will get access to the data? What is the public good in making the data open? How can I, and if you give me access, how do you protect the data privacy? So there are huge set of questions. My little bit of a reading of the standards is that all the dimensions are not completely understood. The complexities are, so they invariably try to look at one aspect of the problem and a narrower aspect of the problem.
So, Vishesh, one of the things you constantly hear is that regulation stifles innovation, right?
Mm.
And I don't know how true that necessarily is. Perhaps there's a balanced approach and a modular approach to, working up to heavier regulation. But in spaces and with outcomes like you've been pointing to throughout our conversation, where, it can be life or death for an
Mm.
individual, at what point is the right point to start to bring in regulation, right? Is it self-regulation, co-regulation, and then heavier forms of regulation? um, and I think in especially in a space like AI and healthcare, the other sort of looming question is questions of liability, right? And that has massive implications for this space. And concerns are like, okay, someone has to take responsibility for decision making, but starting to place liability, is that going to stifle the growth of this space? So, as a technologist, as someone, on the side of developing these things, working with organizations to frame solutions, how do you think about this big word of regulation?
Okay. So let me think about it, how to phrase my answer. I think that when it comes to data and AI use, I don't see how you can have a regulation-free environment, right? I mean, how is that even possible? It cannot be a free for all. There has to be some level of regulation, right? Guidelines and ensuring that those guidelines are followed, and that's regulation for you. In terms of data collection, in terms of maintaining standards and giving the right kind of promise, to avoid snake oil. But all of this requires some bit of regulation. And that regulatory capacity will have to be built. There's no question about it. I am not convinced that regulation and innovation are mutually exclusive, right? I mean, this is said often, but why should this be the true? And what is the theory behind that? That if you have regulation, you cannot have innovation, because you can built-in methods of innovation even with a regulation in place, and it just requires thinking about the problem right. Right. So you can have a fair use of data policy, and uh, so regulation with the data. What does it require? It just requires that you can't use the data beyond the stated purpose. You need some kind of a purpose limitation in the data, right? I mean, that this data will be used only for this purpose, and then, if it is the only way that can be done is that the regulator only allows pre-approved programs. They submit a program, the data processing algorithm is audited, and certain audited algorithms are allowed to run. That requires a regulatory capacity which is enormous. And because you don't have those regulatory capacity, you come up with orthogonal measures like, say, consent manager, or, that is just wishful thinking. That is neither here nor there, right? And those kinds of random thinking may actually stifle innovation. But if you do it right, then there is no reason for regulation to stifle innovation. But to get the right set of regulatory frameworks in place for data, for AI, I think the regulatory capacity is a big challenge, as I see right now. So it's not at all clear how that can be built up. But without that, a free for all, I think that's chaos.
I think that last answer has actually opened up a whole set of other questions, but
Right.
we'll conclude with this. Professor Subhashis, for any regulator who may be listening, anyone involved in that world, and given the constraints, the problems with our regulatory capacity, what is the first priority that regulators need to address when it comes to ethical and operational challenges in healthcare and AI?
I think that understanding the limitations of the technology well, cutting out the snake oil, figuring out the risk, not hide behind responsible AI without clearly articulating that what that phrase even means. And yeah, so understanding the technology, its implications, is deployment scenarios, the realities of the deployment scenarios, and understanding that deployment in South Delhi is not the same as deployment in Jharkhand, right? I mean, and also when you deploy a technology, you will require a manpower that will use that technology, and maybe it's an ASHA worker. So it's impossible to think of the technology independent of the person who will administer the technology. Right? So it's the whole ecosystem. So a compartmentalized thinking is not going to work. So if you have to have regulation, it has to encompass everything.
Thank you so much for joining us today, Subhashish. It's
Thanks. Right.
such an eye-opening conversation.
Um,
Thank you. Wonderful, wonderful conversation.
Thank you.
We would love to hear your thoughts on the episode and your suggestions on what topics you would like us to cover. You can reach out to us through email or find us on our social media. We will link the details of these in the show notes. Lastly, we would like to thank National Law University Delhi for their support in creating the podcast. If you enjoyed the conversation, please like and subscribe wherever you're listening to the podcast. We look forward to bringing you more content. This podcast is created by Center for Communication Governance at National Law University Delhi. This episode was edited by Gopika.